Hello, everyone, and thank you for attending today's webinar, The 5 Keys to Successful Implementation of Contrast-Enhanced Spectral Mammography, which also has been approved by the ASRT for 1 CEU credit, Category A. My name is Bonnie Cowan, Clinical Marketing Leader of Breast Imaging with GE Healthcare, and I am joined today by our expert speaker, Dr. Cathrine Keller, Managing Physician and President of Lake Medical Imaging in Central Florida. Dr. Keller has been a passionate advocate for breast health and yearly mammography screening for more than 2 decades, and has also been instrumental in introducing new technologies for the early diagnosis of breast cancer in Florida. Today's session is part of our 2019 Clinical Conversations webinar series. We've created this series as a platform for you to connect with peers and to share perspectives on some of the most challenging clinical topics in breast imaging. We will be hosting more webinars throughout the course of the year, so be on the lookout for communications as we announce future events. Before we begin today's content, I would like to cover a few housekeeping items. The webinar is being streamed, so volume can be adjusted directly from your speaker control panel on your computer. You can expand your slide area or maximize to full screen by clicking on the arrows in the top right corner. If you have any questions during the webcast, you can submit them through the Q&A widget. We will try and answer as many questions as we can at the end of the presentation. If we do run out of time, please know we do capture all questions and will follow up with the answers via email. After the Q&A period is over, you will have 10 minutes to take the assessment quiz. You can assess the quiz using the pencil widget found on your screen. You will need to answer 5 of the 7 questions correctly to earn 1 CE credit. Upon completion of the test, you will be able to print out your CE certificate by clicking on the yellow icon. Once again, participation time must be met for the GE widget to be active. An on-demand version of the webcast will be available 1 day after the webcast and can be accessed using the same audience link that was sent to you earlier. Now I am excited to turn it over to Dr. Keller.
Hello, everyone. I'm happy to be able to talk about the 5 keys to successful implementation of contrast-enhanced spectral mammography today, because it is just a great test and everyone should use it. I need to let you know that GE supports me, and this is my disclaimer. The agenda is the following. First, I'll tell you a little bit about my practice. Then I'll tell you what is contrast-enhanced mammography and how it works. Next will be the 5 keys. The first key is number 1, the protocol, why and when to use contrast-enhanced mammography. Key number 2 is the implementation, what you need to start. Key number 3 is training for the technologists and the non-techs. Key number 4 is education, teaching the radiologists and the referring doctors. Key number 5 is marketing. After that, we'll have time for some questions and answers. So, I am the president of a privately owned radiology practice in Central Florida. We have 23 board-certified and subspecialty trained radiologists. We're fully accredited by the American College of Radiology, and I'm proud to say that we were the first independent imaging center in the nation and remain the first in Florida to have the prestigious American College of Radiology Diagnostic Imaging Center of Excellence accreditation. We have 5 imaging centers, and they're all nice and sunny because it's in Central Florida. We're building our 6th right now. We're also the radiologist at the 2 local hospitals, the Villages Regional Hospital and Leesburg Regional Medical Center. Together they have about 600 beds. The PAC system there is integrated with our 5 centers, and that's important for the continuity of care so that we can always see the images no matter which of any of the locations the patient has been. Now let's get to the meat, contrast-enhanced spectral mammography. So what is CESM? Well, It's a dual energy, low dose, full field digital mammogram, which is enhanced by injecting iodinated low osmolar contrast. We use the IsoView 370. What happens is that the images from the low energy and the high energy are combined so that you see an iodine-only image that shows areas of abnormal blood flow or enhancement. And next to this woman, you can see this white area in the right CC view there that is from the combined iodine-only image showing a little cancer. How does it work? Well, it's really pretty simple. As long as the CESM is installed on your mammo machine, when the technologist goes into the room, all she has to do is to install it, so to speak, which is to turn to that mode in the gantry. Next, what happens is that you use a power injector to inject the contrast using the same kinds of standards that you use for CT in your imaging center. After 2 minutes, you begin to acquire the images, and you do the same process of the 4 standard images as you do for a regular mammogram. And then you review the images. This is very important for the technologist because if there are any areas of abnormal blood flow highlighted by the contrast, you have to go ahead and take any extra true lateral or spot views right then while the contrast is still in the breast. I'm going to tell you some more detail about this. So, exactly how it works is that we inject the 370 IsoView at 1.5 milligrams per kilogram, 2 to 3 milliliters per second. And after you inject, you have to wait 2 minutes before you start imaging. And there's a little bit of a pause between when you start injecting and the contrast actually goes in. The dual energy exposure is to make the bilateral CC and MLO views. Generally, we start with the breast, right or left, that has some area of abnormality if we're working up something abnormal from a screening mammogram or problem solving. If we're just doing this for dense breasts, you can use whatever is the usual order of your protocol. You have to pace yourself while you're doing this so that the increased heat caused by the dual exposures doesn't slow you down, but that's really no problem whatsoever. You're able to use a single compression for both the low and high energy exposures. Once you have the patient in position and you press the exposure button, it automatically does the low and the high energy. You don't have to do anything else. Then as you watch on the technologist monitor behind the shield, you can see the images come up, and then you'll see the combined final iodine-only image where the background density of the breast is subtracted away, and all you see are areas of abnormal blood flow. So how exactly it works in terms of the timing, this is a nice graph to see it. First you have the injection, and you wait 2 minutes. During those 2 minutes, at about 1.5 minutes in, the person who has hit the timer button on the gantry when the injection starts will tell the technologist it's 1.5 minutes, so it's time to start positioning. By the time you finish positioning for that first CC view, it's 2 minutes, and it's the perfect time to begin imaging. So this shows you that when you're doing the compression, you use the same compression, and you get the low energy, that's the yellow signal there, and then the high energy. Then you release the compression, and there's a pause as you wait for the images to process, and then you go to the left CC and repeat. You do the compression, you make the low energy, and then the high energy image. Again, when you're completed, you release the compression, you see the images come up, and you go to the next one for the left MLO, repeat the process, and then the right MLO. On the bottom part of the screen, you can see that you first will see low energy images that are the same as a regular full field digital mammogram, and the recombined iodine-only images come up as the final thing that you see, and that allows you to see any areas of abnormal blood flow. You can see that there is a little bit of background parenchymal enhancement, and that's very similar to what you see on an MRI. but it's easy to learn how to read through that, and it doesn't pose any problem. Now let's talk about the 5 keys to the successful implementation. Number 1 is why and when to use contrast-enhanced mammography, which is the protocol that you'll develop between the technologists and the radiologists to use most properly at your facility for your patient population. Number 2, what you will need, the implementation, the different tools and things you need to set up. The key number 3 is training. The technologists and non-technologists need to be trained about this. Number 4, education. This is very important. Educating the radiologist about the test, its benefits, when to recommend it, and how to interpret it, and also educating the referring doctors so that they will know what to do if the radiologist recommends it and when they might want to recommend it on their own. The last key is marketing. Marketing is very important to get this process launched and make it effective in your practice. Key number 1, why use contrast-enhanced mammography in the first place? Well, the most important reason is for increased breast cancer detection. That's the whole aim of breast imaging in the first place, and I'll show you how effective that is. Next is for the patient. This can be very beneficial for the patient. And last is for the radiologist, because the radiologist's confidence in the diagnosis and speed to diagnosing breast cancer is enhanced with this test. I can tell you that of all of our radiologists that use this, if we could only use one imaging manner for looking for breast cancer, we would use contrast-enhanced mammography. Forget everything else. It's the best breast imaging test known to man. So, finding more breast cancer with contrast-enhanced mammography. We know that the sensitivity of full-field digital mammography is really pretty good, about 85% in fatty breasts and breasts with scattered density. But in the dense breasts, the one that have heterogeneously dense and extremely dense breasts, it's only about 65%. So that means you're missing about 1 in 3 breast cancers. Contrast-enhanced mammography, however, is not limited by the breast density because all that dense tissue is subtracted away and all you see are the areas of abnormality. So what does that mean practically? It means that the additional breast cancer detection rate per 1,000 women compared to regular 2D mammography is 10 to 13 per 1,000. That's huge, and it is almost exactly the same as breast MRI. So you're doing a huge service by using this test. Here's an example of a patient from my practice. We only did the contrast-enhanced mammo on her because she had dense breasts and a family history. So when you look at that, you see some splotchy areas and you wonder, well, what's it going to show? Maybe something, maybe nothing. Well, here's what happens. On the CC and the MLO view, you can see this cancer. It's very easy to see. And if you look back at the mammogram from before, it seems like it was going to be this place here, but actually it's right there. So that was a surprise. And it was a cancer that we wouldn't have found because all of her mammograms looked the same year after year. What's another reason to use contrast mammography? Well, it's for the patient. Patients will have much less anxiety compared to having an MRI because they can come to the same place they always come to, the mammo center, not to a new, unusual location like the MRI. They're seeing the same technologists that they've known for years, and they're having an exam that seems exactly the same as a regular mammogram. The length of the exam is about 5 to 7 minutes, so it's really essentially the same as a regular screening mammogram. They can get the same day results. They don't have to wait for days or a week or more the way they do for an MR because of all the processing and time for interpretation. Also, it costs much less than an MR, and it's much faster than an MR. Even with the abbreviated screening breast MRI, the fastest those happens to be about 10 to 15 minutes. So at 5 to 7 minutes, that's faster. And lastly is the safety. You know that iodine has been used in imaging since the 1920s. And if it were going to have any long-term deleterious effects, we certainly would have figured it out by now. Gadolinium, on the other hand, is a little bit of an unknown. We've seen recently, over the last few years, that it accumulates in all the tissues of the body, most notably in the brain and the bone and the skin. So right now, as long as you have normal kidney function, it doesn't cause any problem. But I really have to wonder, what's going to happen 30 or 40 years from now? Will we find out that there's something bad about that accumulation? And the example that comes to my mind is that originally doctors used to recommend cigarette smoking as being healthy. And look what we found out happened to that. So I just think as long as there's a test that you might do repeatedly year after year, starting with women who are young and with dense breasts, we can err on the side of safety and use iodine unless there's a compelling reason to have the breast MRI. And why is contrast-enhanced mammography good for the radiologist? Well, you get a huge increased diagnostic confidence because just like that lady I showed you a few slides back with her dense breast, that's really hard to figure out what's going on there. But once you do the contrast-enhanced mammogram and you see the abnormality, that is clear-cut. Everyone can diagnose that. The janitor can see that there's something the matter there. And then you can do a targeted ultrasound and find the abnormality and biopsy it. It's also good because it helps you to decrease unnecessary extra imaging and biopsies. When you might have a person come back and have add views in ultrasound or come back in 6 months like a BI-RADS-3, you could just do the contrast-enhanced mammogram and you know right away everything's okay or it's not okay. Likewise with unnecessary biopsies. If you see something that seems quite concerning but it doesn't enhance on the contrast-enhanced study, well, the negative predictive value is so high you can feel comfortable eliminating the biopsy and just following it up later. The other thing is that you're getting that huge increased cancer detection rate of up to 13 per thousand. And it's very sensitive, nearly as much as a breast MRI, and has a high specificity, meaning if it's positive, it's almost always going to be a cancer. There are few false positives, and I'll talk more about that later. So, when to use the contrast mammography for your protocol. These are the reasons that I use it in my practice, as do the other breast imagers. And our usage has developed somewhat over time, but I think that numbers 1 through 4 are the most common reasons that we use it, and then there are the other 3 reasons. So let me tell you about them. Sometimes it's for problem solving in a BI-RADS-3 kind of situation. So here's a woman that you've done some workup after her screening examination, did add views, ultrasound, you're still not sure, and you say, well, you know, how about if you come back in 6 months and we'll keep doing this for 24 months and make sure everything stays the same. Well, that's not so great for some persons because it's extra time they have to take off work, extra cost to return and have these examinations, and it's just not convenient. Besides which, there's a lot of anxiety involved with saying, gee, is it something bad? It's not something bad? Wouldn't you rather know right away? So instead of doing every 6-month imaging for a while, you could just do the contrast-enhanced mammogram. And if it's normal, great. She goes back to her annual screening mammography. If it's not normal, then you can do the extra things you need right then, and you don't have to wait 6 months. Likewise with problem solving. Sometimes you're just not quite sure that the results after you've done some workup are adequate to convince you, and if you did the contrast-enhanced mammogram, then you can be sure. Number 2 is a patient that has no prior exams or it's the baseline. There are women that come to our practice and their last mammogram was 10 years ago or something like that, so there's no way we can get their prior mammogram. Or it's the first mammogram in a young woman that has very dense breast tissue and lots of bilateral nodules. Well, what are you going to do? You can't do add views in ultrasound, spot compression views in multiple locations on both sides, that's a lot of extra radiation, and it's inefficient and uncomfortable. So the single best way to solve that problem is to just do the contrast-enhanced mammogram. It's fantastic. It allows you to set a new baseline, and then going forward, you know what you saw is all fine because you have both the contrast-enhanced iodine-only images and the mammogram part to compare with your subsequent years of mammograms. Number 3 is for women who are high risk or have dense breast tissue and you need some supplemental screening. We know from what I mentioned before that you can miss as many as 1 in 3 cancers in ladies that have density C and D breasts, so you need to do something extra. And especially if they have increased risk from a family history of breast cancer, this is an excellent tool to feel very confident that you're finding everything abnormal and you're not finding false positives. Number 4 is for the patients that are recalled from a screening mammogram. Now you might do add views in ultrasound, that's fine, but sometimes there are bilateral abnormalities. So just like the person that has no priors or it's their baseline examination, when you have bilateral abnormalities, using the contrast-enhanced mammogram is very efficient, effective, and has high diagnostic confidence. The next one is for women that can't have breast MRI. Some can't have it because they have some implanted device like a non-MR compatible neurostimulator, pacemaker, some other device, so they're just not able to have it. Some are allergic to gadolinium, so they can't have the contrast enhanced. And the non-contrast breast MR is still not ready for prime time. And then there are some women for whom lying prone because of their age and arthritis, maybe they have kyphosis, is just too uncomfortable for them to do that and be still. Therefore, the contrast-enhanced mammogram is a perfect alternative. Next is for extensive disease after diagnosis or after adjuvant chemotherapy. There have been several studies that show that the contrast-enhanced mammogram is completely equivalent to the breast MR with contrast for looking at changes in the tumor after adjuvant chemotherapy and for determining the extent of disease, whether there's more than one area in the same breast or whether there's any contralateral disease. And that's a common reason to do breast MRI. Also, number 7, for a woman who has already had breast cancer and now has had her lumpectomy and radiation therapy and has that big retracted scar in the lumpectomy bed, it can be really hard to see through that scar tissue and find out what's going on. Well, the contrast-enhanced mammogram is perfect because it sees right through that. There are some practices in Europe that use contrast mammography quite a bit, and they always use that as the annual screening tool for women that have had lumpectomy and radiation. Okay, so let's move on to key number 2. What do you need to actually start doing this in your practice? Well, you need to install the Celebrite onto an existing unit if you didn't already purchase it that way. Now, compared with using molecular breast imaging, this is great because you can have a mammogram unit and you can use it for the contrast-enhanced mammo when you want to and use it for regular mammography all the rest of the time. You'll need a power injector, and a single barrel injector is fine. We use an iStat for spot creatinine checks in case the patient has not had one in 30 days. You need to get IV access, and that can be the technologist, if you have a nurse in your facility, or a phlebotomist. At my facility, we have phlebotomists to start the IVs for CT and MR, so that's an easy thing to do. I know that some persons I've spoken to are in a breast imaging center where there is no CT or MRI, and they say, well, you know, what am I going to do about the IV access? How will I manage that? Well, what you might do is decide to schedule all of your contrast mammograms on the same day, one day a week or whatever you need to do, and just have a phlebotomist employed half day. and that would take care of it for you. In the room where you're doing this, you need to have a sharps container. You also have to pick a room for where you're going to set things up for the injection, and it can all be done within the mammo room. And you need to have some basic emergency equipment. Contrast reactions are really quite uncommon, but they do happen from time to time. So let me show you what we do. What we do at Lake Medical Imaging is exactly that. We have the single head injector. We use the IsoView 370. We have the phlebotomist start the IV and check the creatinine if necessary. We had a consult room that we converted to be both a consult room and a place where we start the IV, and we just stocked it with the basics that we needed. The basic emergency equipment that we keep in the mammo room, because that's where the injection takes place, are really few. You don't need to buy a crash cart. All you need is a stethoscope, a BP cuff, some injectable Benadryl, and injectable epi. You can even have an EpiPen. We also have a yoga mat in case the patient has a vasovagal reaction, because there's really not room in our mammo suite for a stretcher, and that has worked out well. So how often are there any reactions at all? It turns out we've been doing this procedure in our office since January of 2014, so that's 5.5 years, and we've never had any serious reaction. We've had maybe a handful of vasovagal sorts of problems and 1 or 2 patients that had hives. So it's all been very easy to manage. It's not like the contrast before the low osmolar was around. It's really quite safe these days. Let's move on to the next key, which is training. Who do you need to train? Well, you have to train the radiologist. You need to train the mammotechnologist. You need to train your schedulers, and you have to get the IT involved for what they need to do in the PACS. So how about training the radiologists? You need to train them in interpretation, how to read the study, because it will be something new for most of them. You need to help them understand when to recommend the examination, and that goes back to the protocol that we mentioned before. And you need to give them a bibliography of references and videos to watch and other things so that they can learn the most at home. They do not need a specific 8-hour course the way you do for DBT or whole breast ultrasound, because it's just an adjunct to mammography. How about the technologists? Well, they can use some of the same training tools as the radiologists do, and then the applications persons from GE are very good. Also, part of the technologist's job is to learn about seeing what looks abnormal on the images as they come up when you're doing the contrast-enhanced exam, so that they will know when they need to take any true lateral spot view or anything else, because there's really not time to run and interrupt the radiologist, get her or him to come and look on the screen. The contrast is only available for imaging for about 7 to 10 minutes after the injection. You also need the technologist to help with the recommendation by learning how to educate the patients about breast density and about what contrast-enhanced mammography is. And that turns out to be pretty easily. What about training the schedulers? Well, when you set this up in your system, at the beginning, we left 45 minutes for each examination. But pretty soon we realized that we only needed 30 minutes. You also have to train the schedulers to make sure that the referring doctors, when they order the examination, use the ultrasound, if needed, conditional aspect, because if you find something abnormal on the contrast-enhanced examination, you need to do a targeted ultrasound in order that you can find the area and decide about whether it can be targeted for ultrasound-guided biopsy. As far as IT, the last group to train, you need to have them add the exam to the PACS and all the things that go along with the IT for adding a new examination to the PACS, adding a template, making sure everyone involved on that side of things is familiar with this new procedure. How about training the radiologist? Turns out that's easy, which is great. If they can read breast MRI, they can easily read this. Even if they can't read breast MR, they can easily read the contrast-enhanced mammogram. There was a great review article that I have the title page here. It was a systematic guide to interpretation and reporting. That was very good. But there are many references. This is just a smattering of all the references. There are white papers in the SBI. There are review articles in radiographics. There are videos to watch that have lots of examples. And as the years go by, there have been more and more articles. Last year and this year already, there have been many, many, many. And if you just look at Aunt Minnie, you'll see that it's frequently reported there. So who recommends a patient to have the contrast-enhanced mammogram in the first place? Well, most of the recommendations come from the radiologist because they'll see a patient that has dense breasts and needs something supplemental, or they'll see a patient where the problem-solving technique with adviews and ultrasound didn't resolve the issue, or a patient doesn't want to have a BI-RADS 3 and have 6 months evaluation every so often. They want to figure out what's going on right now. After educating the referring doctors and the breast surgeons, some of them will directly order the Cenobrite. So because of the radiologists and the referring doctors ordering it, you have to make it easy for them to order the contrast-enhanced study. And a lot of that has to do with the reporting of the results and with the order forms. So I'm going to show you what I did to make it easy, because before I did this, it wasn't easy enough. What I did in the reporting template that comes up for the radiologist is to make a little macro button, or you could have a voice recognition macro. And you'll see with this purple arrow, there it is, it says Ceno blurb for the Cenobrite blurb. So what that blurb says is the following. In this patient with dense breasts, consider additional breast imaging with contrast-enhanced spectral mammography. Then you have the option of saying that you want that now, you want it within 6 months, or you want it at the time of the next annual mammogram. After that, it says, if you would like us to schedule this exam, please fax an order to blah, 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 blah. So that goes direct to scheduling. And if the patient has some other risk factors, then I'll just voice recognition that part into the leading sentence. So I'll say, in this patient with dense breasts and both personal and family history of breast cancer and 2 first-degree relatives, or whatever the case may be, so that they really know why it's important to do that. Or in this patient who has no prior mammograms and bilateral abnormalities, dense breasts, blah, blah, blah. You just tell them what they need to know in order to understand why you're recommending this. That makes it very easy for the radiologists in the practice who are reading the screening mammograms to initiate the recommendation for the contrast-enhanced mammogram. How about the conditional order? Well, this is the part where I mentioned that the schedulers have to make sure the referring doctors order ultrasound if necessary. So on our order, which of course is electronic more than paper now, there's a place where you can check off the Cenobrite. And then down here at the bottom, it says ultrasound or additional views if necessary. A conditional order such as that is completely compliant with insurance and Medicare and Medicaid regulations because you're only doing it if necessary. It's not a standing order. This is important to help everyone understand, saves time and trouble for the patient, the radiologist, and most importantly for the referring doctor. They really do not want to have to be interrupted in their busy days to talk to the radiologist about some lady that needs something extra. They'd rather that you could just do it. This is also something for the marketers to help educate the front desk staff and the office manager at your referring doctor's offices. Because the sooner that the patient gets the contrast-enhanced mammogram and the ultrasound if necessary to decide about a biopsy, the faster the breast cancer gets diagnosed, and that's the best for everybody. How about the report? Well, the report is important when you do the examination so that you include the elements that allow you to bill for the examination and get the proper reimbursement. So the title is generic. It says bilateral contrast enhanced digital mammogram. The indication, if you're only using it for dense breasts, is an ICD-10 code in conclusive mammogram, and that is reimbursed. If you have a reason like a breast lump or whatever the other reason is that's a more specific indication, you can put that too. In the technique paragraph, you have to say exactly what happened, and here it tells that contrast was administered with the use of a power injector. Using digital mammography, standard images were obtained, followed by high-energy, low-dose, tailored to iodine detection images. The recombined iodine-only images are created in each projection, and this examination is reviewed with the aid of CAD. We use CAD in our practice. If you don't, you leave that sentence out. For the contrast, you have to put what you used. Contrast is the IsoView 370, and then you put in how many cc's you actually used and what was administered IV. The rest of the elements are standard, what your comparison views were, what the breast composition was, and then under findings, if everything's normal, you just say no abnormal enhancement. If you were looking at something in particular, like in this case, you can say in particular there is no abnormal enhancement in the asymmetric density in the upper outer quadrant of the right breast, so that everyone knows you're paying particular attention to that. Next, after you tell the results for the right and left breast, you have to make some statement about the degree of background parenchymal enhancement, and that's pretty similar to what you do with the breast MRI. So there's minimal, mild, moderate, and severe. And that's a separate dictation issue. We can talk about interpretation and findings in another talk. And then you give your impression. Well, if everything was okay, then whatever I saw in the mammogram means it's not bad, so it's a BI-RADS 2, and the lady can return to her 12-month follow-up. And in this case, she had been recommended to have a 6-month follow-up BI-RADS 3, but I just said no longer necessary because we solved the problem now. So we saved everybody time, trouble, anxiety, and cost. What about education, which is the number 4 key? Well, the way the blackboard says, it's true. Education is the key to success. The more we all know, the easier it is. So, what are we going to do about all this? It's very important in understanding when to use contrast-enhanced mammography to understand the implications of breast density. I touched on that earlier, but I'm going to talk about it a bit more. Remember that in all women, the sensitivity of mammography for detecting breast cancer is about 85%. But if you have dense breasts, it's only about 65%. So that means that about 1 out of 3 breast cancers might not be seen in women with dense breast tissue just because the dense tissue hides the cancer. How about the reverse of that? How many breast cancers are in women with dense breasts? It turns out that 71% of all breast cancers are in women with dense breasts. So that's well beyond the majority of them. The real limitation of mammography is the masking effect of the dense breast tissue. So on the left here is a woman that has mostly fatty breast tissue, and it's easy to see the fibrous and glandular tissue on top of the fat. On the right is a lady that has D density, extremely dense. The only reason this matters is that a mammogram is black and white. The dense normal tissue is white, but cancer shows up white. So to see white on white is like trying to see a snowball in a snowstorm. It's much easier to see white against a dark background. Well, breast cancer is mostly in these women that have the dense breasts. And what do we know about that besides that they're the ones that get it? Those cancers tend to be larger. They're higher nuclear grade, which makes them worse cancers. These cancers more frequently at the time of diagnosis have a positive lymph node in the axilla, and they have a worse overall prognosis or outcome. And then here's one that we see all the time. You know, someone will talk about, well, my friend just had a mammogram 4 months ago and it was normal. Then she found a lump and now she has breast cancer and it's already in her lymph nodes. Well, that's terrible. What happens? It's because it was hiding behind the breast tissue. If you look at all the interval breast cancers, and those are ones that are diagnosed within a year of a negative screening mammogram, those ladies are 18 times more likely to have dense breast tissue. What about these ladies with C and D density? Well, if you look at ladies before menopause, about 2/3 of them have dense breasts. And after menopause, about 1/4 of them have dense breasts. So you see that the estrogen and progesterone have an effect, but that's not the whole answer. So if you look at the whole group of women before and after menopause together, it's about 40 or 50% of women. How many of them understand that they have breast density and know anything about it? Even with the breast density reporting laws that have been passed, it turns out that still about 3/4 of women are not aware that they have dense breast tissue. So what factors are the most important when you look at breast cancer risk? You know that only about 15% of women that get breast cancer have a positive family history or some genetic risk. Nevertheless, it's important if you have a first-degree relative that has had breast cancer. So that's a mom, a sister, or a daughter. If you personally have had a history of a benign breast biopsy, if you have the C and D dense breasts, if you've had your first child at age 30 or older, or if you never had any children, and if you are overweight, which is the BMI over 25 and you're after menopause. Remember that the normal BMI is up to 24.9, overweight is 25 to 29.9, and obese is 30 and over. So, the idea about when to do anything extra is to triage patients by the risk of their breast density masking or hiding a breast cancer. The sensitivity of mammography is low enough in dense breasts, missing 1 in 3 potentially, to consider supplemental screening. And this is the crux of all of the laws being passed by states to have notification of dense breast tissue. There's also a federal law that has been proposed and passed but not put into use yet. That's still being worked out. How about if we try to look at risk and density together and figure out who are the ladies that are going to benefit the most from some supplemental screening? Well, over here on the left, you see the lifetime risk of breast cancer can be divided into women with a high risk, women with an intermediate risk, and women with average risk. So remember, average risk is that 1 in 8 women over their lifetime develop breast cancer. High risk is you have a 20% or more lifetime risk of breast cancer. So in figuring out in the population who falls into each of these categories, it turns out only about 6% of women are high risk, about 1/4 of women are intermediate risk, and the vast majority, 70%, are average risk. Well, also, besides risk, there's the breast density. So how about with breast density across the top? You know that the almost completely fatty women, breast density A, are about 10% of the population. B, the scattered fibroglandular tissue, is about 40% of the population. C is the heterogeneously dense, and that's about 40% of the population. And D, extremely dense, is only about 10% of the population. If we try to marry those two thoughts, the risk, lifetime for breast cancer, and the breast density, then we can find out the following. Of the high-risk women, regardless of what their breast density is, if you multiply it out, that's still only about 6% of women, regardless of their breast density, are at high risk. Those are important women to capture and use extra screening such as breast MRI. But the majority of women are intermediate or average risk. So if you look at which amongst those women are going to be extra difficult to diagnose breast cancer because of their density, which of them have C and D density, That's almost half the population of women. They're not high risk lifetime, but they're high risk because of their density combined with either normal risk or intermediate risk. So they are the ones particularly important for us to pay attention to, not only the high lifetime risk women. So if we want to help find breast cancer earlier in the ladies that have average and intermediate risk and have more breast density that we know is going to hide the cancers, what can we do? Well, let's think about how many more cancers you can find with all the different choices that we have for breast imaging. If you look at the comparison of regular 2D mammography with digital breast tomosynthesis, that's the 3D, the ICDR, which is the increased cancer detection rate, is about 2 per thousand. Some studies it's a little more, some it's a little less. 2 per thousand is great, but that's a small number. How about with whole breast automated ultrasound? Well, that's even better than DBT. You get 3 to 5 per thousand. That's great. But initially when you first start doing ABUS, you can have as much as a 25% recall rate, which is pretty high. It takes doing it for a year or so before you get your recall rate down to a normal amount. How about with contrast-enhanced mammography? My personal favorite. Well, here's where you get the 10 to 13 per thousand increased breast cancers that you can diagnose. MR is really pretty similar, 12 to 14. So there's tremendous overlap there, and they're really quite similar. What's the difference between MR and contrast-enhanced mammography? Well, the sensitivity is really about the same, meaning how well can it find something that's abnormal? What will contrast-enhanced mammography miss that MR might find? Well, there are two things. You might miss a cancer that's smaller than 4 millimeters or about 4 millimeters. And you might miss a low-grade DCIS. Now, it's always important if a cancer is missed, but certainly one might argue that if you don't see a low-grade DCIS, you're not causing any harm because the majority of those do not go on to cause morbidity and mortality in the patient. It's something that they have and is one of the kinds of breast cancer that's considered to be sometimes overtreated or overdiagnosed. If a cancer is only 4 millimeters and you don't see it, then it's probably one of the ones that's slow growing, and you can review that again in a year, and it turns out that you have not made any error that's harmful to the patient. What about the specificity of the diagnosis? Specificity means that you're finding something that really is a cancer, and you're not finding something that turns out to be normal when you biopsy it. Well, we know that MRI is very sensitive, but it also has a high false positive rate. So the specificity of contrast-enhanced mammo is better than MR. It has fewer false positives, so that means that you have fewer patients that have to go on to a biopsy that shows only normal tissue. The kinds of things that are false positives for contrast-enhanced mammo are pretty similar to the things that you see on MR. So what can those be? And you can also learn to recognize them. A lymph node can show up, just like with MR. A fibroadenoma can enhance, just like MR. A papilloma can enhance, just like MR. With a papilloma, because you can't really tell the difference between a papilloma and a papillocarcinoma until you remove it, whether it was enhancing that way on an MR or a Cenobrite, you're still going to find it with the targeted ultrasound and probably do a biopsy. They are particularly pesky, those papillomas, because sometimes on ultrasound they're taller than wide and they can look fairly suspicious. And there's not much way around that. Another thing is that there's the background parenchymal enhancement that is a problem for MR, and it is less a problem on the contrast-enhanced mammo because if you have older mammograms, you can see areas that enhance and might be troublesome, but if you look back on the older mammograms, you can see, well, this appearance, the part that's enhancing, has been there for 5 years, so it can't be anything but normal background parenchymal enhancement. So the sensitivity and specificity together means that the positive predictive value, how often something you find abnormal on the contrast-enhanced study turns out to be cancer, that's the PPV, is actually a little bit higher for contrast-enhanced mammo than for MR because of the fewer false positives. What else is good about contrast-enhanced mammo? Well, you don't use gadolinium, you use iodine. And I mentioned before, there's no harm that we know about for the gadolinium accumulating in your body as long as you have normal kidney function, but nobody really knows over the long haul what that's going to mean. What are they going to tell us 30 years from now about gadolinium? I don't know. So if you really need to have it, absolutely have it. Important for your diagnosis. But if you have an alternative, you might want to choose that. Another thing compared to MR is that you do not have to lie prone. And for some persons, lying prone and holding still is very uncomfortable. And lastly is that there's a business advantage. Now, while the reimbursement for a contrast mammo is less than for an MRI, because of the length of the time it takes to do the procedure, you can do more MRs of other body parts per hour than you can do breast MRs. So from a business point of view, there's greater revenue produced by doing other sorts of MRs, and you're saving your machine for those studies. All right, what more about education is teaching the technologists and the patients about breast density and why it is important. This is a sheet that I developed, and what I do when I tell the patient about their breast density and why they might need the Cenobride or some other test is to use this as a teaching tool. The technologists also use it as a teaching tool to help explain the breast density. So I show them these 4 CC images and tell them this is 4 different ladies, left breast compressed top to bottom, and I show them with my hands compressed top to bottom. And I show them this. You see that the mammogram is a black and white picture. I orient them for the anatomy. Here's the chest wall, here's the skin, here's the nipple. This is the armpit side, and this is the breastbone side. You see that a mammogram is a black and white picture, and the dense tissue that we talk about is normal tissue, but it shows up white. This lady has almost none. This lady has scattered a little bit more. This lady has heterogeneously dense. Most of her breast is filled with it. And this lady is extremely dense. That's about all she has is the dense tissue. Well, who cares? The only reason you care is that breast cancer shows up white. Well, to see white on this gray background is a whole lot easier than to see white on white. That's that snowball in the snowstorm masking effect that I mentioned. So then I help them understand that in density A and B, the sensitivity for diagnosing and finding breast cancer is about 85%. But in C and D, it's only about 65%. So that means that as many as 1 in 3 women, I can highlight this area in the lower corner here, will have their breast cancer missed just because of breast density alone. On the same piece of paper on the other side is more information. So all in one piece of paper, you can give them the information that they need. So what happens next is I help them understand that if you have dense breast tissue, most breast cancers, 71%, are diagnosed in ladies with dense breast. Well, what are they going to do now that they have dense breast? Just be scared? No. I tell them that the reason that you might not have known what your breast density was before and that it has an increased risk of breast cancer because of the masking effect is that in the past there really wasn't anything extra to do. Well, now we have digital breast tomosynthesis, MR, ABUS, contrast-enhanced mammography. So now it's well worth your while knowing about your risk related to your breast density. And then I tell them, what could you do? Well, I can tell them if they have average risk versus intermediate risk versus high risk, and then correlate that with their density. What kind of imaging might they have? Well, there isn't any hard and fast rule anywhere in the literature about what to do unless you are someone who is at high risk. In that case, regardless of your breast density, you're going to either have serial contrast-enhanced breast MRI if your lifetime risk is greater than 20%, or if you can't have MR, you might have contrast-enhanced mammography. And some women actually alternate between the two. If you're at intermediate or average risk and you have dense breast tissue, well, then there are a couple things you can do. What I've been doing in my practice and has worked out well in terms of finding cancers is that for average risk women without any family history, but with high density, category C or D, then I think about doing the digital mammography with 3D and the A-bus. If the women have C or D density and they have average or intermediate risk, or especially if they have busy breasts with lots of nodules on both sides, or they have a family history, then I'm more comfortable with the higher breast cancer detection rate of the contrast-enhanced mammogram. So I'll tell them, why don't you have your annual study with the contrast-enhanced mammogram? And you see so much that you probably only have to have that every other year. And in the years that you don't have that, you can have a mammo and A-bus. And that's a great way to make sure that you're using all the different methods you can. There might be something that you can see on the A-bus that you wouldn't see with the contrast-enhanced mammo. Just like there are things that you can see on a mammogram, microcalcifications, for example, that you're not very commonly going to see on A-bus. So it's good to try to use as many different modalities and different ways to look at the breast as you can. The other thing is that there are these pocket cards that the technologists can keep, and referring doctors really like these because it's an easy way to remember about the 4 kinds of breast density, and especially for referring doctors who are not imagers, it's a great visual, and you help them learn about the snowball and the snowstorm statement and show the fatty progressing up towards extremely dense and how much difference that makes in being able to see a white cancer on top of that white tissue. On the back of this card is some additional information that has references, and you can personalize it for your practice with your own logo. And it talks about the masking effect of dense tissue, and that dense tissue is normal and present in about 40% of women, what its increased risk is, what you need to do, still have your mammogram, but think about some supplemental screening like the whole breast ultrasound, contrast-enhanced mammography, or breast MRI. The last key is marketing. So with the referring doctors, we talk about going to see them with a lunch and learn and show them the GE flip book that has that image that you turn the page, you can see the cancer from the dense breast tissue, these density cards that I just talked about, the handouts that I just showed you about breast density, we can leave them for their patients, and order pads with the conditional ordering and teaching them how to find that in their EMR. What kind of doctors do you want to target? The OB-GYN docs, primary care doctors, oncologists, breast surgeons, and don't forget the PAs and the nurse practitioners. They are very thankful to have additional information about this. And how do you do the marketing? Well, you can go to women's organizations and give lectures. Breast cancer support groups are an important place. Speak to nurses, nurse practitioners, and PA groups directly. Sometimes the local hospital foundation has events and you can speak at those. Sometimes you can speak at events coordinated with the American Cancer Society. You can also have a booth set up at different events, like at health fairs, at walks, like the breast cancer awareness walks, or even if it's for another disease entity, you can set up and talk about things. You can be present at fundraisers for different organizations and have a booth. And at the opening of some new location, you can always have a booth. Lots of times our marketers go and our lead interpreting tech or one of the techs who's familiar with breast density and our different imaging modalities for breast imaging, and some of these the radiologist is at too. How about the marketing you need to do yourself? Well, you absolutely need to put the information on your website with all the explanation and some references. There's some really nice videos that you can put on there for patients to watch. Also think about social media, Facebook, Twitter, LinkedIn, and whatever blog you use to post things. Internal marketing is important too, so that means in your office waiting room, we have a TV screen and we have information about the practice and about the radiologist that goes through that. That's both in the general waiting room and in the women's imaging part of it. In office literature, you can have those information sheets I showed you that teach about breast density and what to do about it so that patients can look at those. And then when there's something new or something important you want to tell the public about who's coming through your office, you can have an easel with a big sign that's a poster size, and that's a great way to announce new modalities that you're using, or especially when you start doing contrast-enhanced mammography. Okay, so now we're at the end. In order to reiterate what we talked about in a summary, what are the 5 keys to successful implementation? Your protocol, which is when and why to use it. The implementation, which is all the tools that you need in the room. The training for techs and non-techs. Number 4 is education for the radiologists and the referring doctors. And number 5, what we just talked about, which is the marketing. Why are you going to use the contrast-enhanced mammography? Well, to find more breast cancer, to decrease patient anxiety so that they're in a familiar place and they get an answer right away. It's inexpensive compared to MR. It costs only 40% the cost of an MR. It's fast with immediate results. The procedure is done in less than 7 minutes. I look at it, I see the result, I go tell the patient right away. And compared to an MRI, there's no gadolinium, which might in the long run be a risk, we don't know. And there's no lying on your belly, no lying prone, which is uncomfortable for some persons. When are you going to use it? Remember we talked about problem solving in BI-RADS 3. If a woman has no baseline examination or no priors, any woman that is at high risk and dense breasts who needs supplemental screening, or the 5 to 10% of recalls from screening, if an MR is contraindicated, if the extent of disease needs to be evaluated after diagnosis or chemotherapy, and in women after a lumpectomy and radiation. So the complete summary is that you're going to increase your diagnostic confidence because of the high sensitivity and specificity. You improve the patient experience because it's fast, there's less waiting for a result, and there's less anxiety, less than a 7-minute examination. And you decrease cost. It's less expensive, it has fewer false positives that lead to other exams, and it leaves your MR open for other activities. So that's it. If you have any questions, here's my email, and there is a nice article about it with a patient that I found a very small 4-millimeter cancer right there. So that's all for me, and now we can go on to the Q&A.
Thank you, Dr. Keller, very much. It was a very informative presentation, and appreciate you sharing your experience with contrast-enhanced mammography and the 5 keys that you've really found to help you be successful in implementation. Being that we are kind of slightly over our hour, I think what we'll do is we will address the questions post the webinar via email. We've gotten quite a few questions in, and so we'll make sure that we address those post the webinar. And so I'd really like to take this time to thank Dr. Keller again for sharing her experience with us today, and also for our audience for joining the webinar. On a last note, as mentioned earlier, there will be many more clinical conversation webinars throughout the course of the year, so please watch your email for announcements and upcoming events. And with that, this concludes today's webinar, and again, thank you very much.
Bonnie.